Dear Professor Vin, thank you very much for this kind invitation, allowing me to participate in this meeting. Heart failure and cardiorenal syndrome from a nephrologist's point of view, and it really doesn't make a difference how you look at the combination of diseases. As you see on the left side, if you take a German cohort of patients with kidney disease with decreasing GFR, you see the incidence of heart disease increases. Or if you look at the Asian cohort of patients with heart failure, you see that comorbidities such as diabetes, kidney disease, or the combination thereof is a lot more frequent. So those two problems are somehow interrelated, and of course you all are aware of the classification of cardiorenal syndrome. At this point, I'd like to emphasize that it does not always have to be cardiorenal. It also could be the other way around. It also could be renocardial. And in order to pick that up, it is really important to think of that differential diagnosis and look at the urine, and not just the creatinine, look at the urine. And basically you need three things. You need a dipstick examination to detect cells and maybe some protein. You need the, at present, most sophisticated way to look at albuminuria, which is the urine albumin-creatinine ratio. And then you need a nephrologist whom you can call. You don't have to send every patient to a nephrologist. You just have to be aware of whom to get in touch with. Why is that, from my perspective, important? Because you might pick up diseases that kind of look like cardiac disease but aren't. There might be such a differential diagnosis as myeloma, which could present with respect to nephrotic syndrome, and you might think this could be heart failure with preserved ejection fraction. And as a matter of fact, edema could be secondary to nephrotic syndrome. There might be amyloidosis from multiple myeloma masquerading as left ventricular hypertrophy, and there could be vasculitis, pneumonia, or active glomerulonephritis presenting as cystitis. A rather simple approach to detect those few true renocardial syndrome. But now let's look back at the ways more common complications where you have a driving cardiac problem, usually going along with some sort of systemic or local overexpression of aldosterone, which then leads to sodium and water retention, cardiac fibrosis, vascular injury, and that translates into congestion and heart failure, or hypertension, renal fibrosis, and renal failure. And this is what we've been dealing with over the past years, and you already highlighted the importance of these four therapeutic concepts: mineralocorticoid receptor antagonism, beta blockers, SGLT2 inhibitors, and ARNIs. And from a nephrologist's perspective, this is quite simple because most of these drugs also remedy chronic kidney disease. Just comparing CHF and CKD, you see SGLT2 inhibitors, and we've been talking a lot about those. They're number one recommendation for both. Spironolactone is, as you have a lot of experience with, quite important in heart failure with the reduced ejection fraction. In chronic kidney disease, actually it's unclear, and there's some data showing that you have a lot of problem with hyperkalemia. But looking at the newer mineralocorticoid receptor antagonist, the non-steroidal finerenone, you know, in CHF there are data coming up that this is quite a good drug for heart failure with preserved ejection fraction, and in diabetes with renal injury. It has to be with renal injury. It has been approved in the European medical agencies. ACE inhibitors, ARBs, of course, and ARNIs, a drug that you use quite frequently, aren't graded in nephrology, but if you look at the studies where actually people used ARNI versus a just regular ACE inhibitor or sartan, and looked at the renal injury, you can see right out here on the right side that overall the hazard ratio for renal injury is always below 1. So don't worry about renal injury from ARNI. Don't worry about using it in patients with chronic kidney disease. Another concern is acute kidney injury from using these drugs. And of course, if you use a substance that takes out volume, such as SGLT2 inhibitors do, people early on were concerned that this could translate into acute kidney injury. But actually, the contrary is the case. As you see in this huge meta-analysis published a couple of years ago, acute kidney injury, the red bars indicate, okay, it's starting a life of its own. Okay, so, yeah, okay. Yeah, now, as you see in these bars, actually, whether patients have CKD with diabetes or without, if you use a SGLT2 inhibitor, the incidence of acute kidney injury is even less than if you use a placebo. Another problem frequently encountered in patients treated with ACE inhibitors and mineralocorticoid antagonists is hyperkalemia. And I'm sure you all have seen figures like that, where you actually see that with increasing potassium, specifically in patients with kidney disease, heart failure, and diabetes, the mortality goes up. But you have to keep in mind that these studies were usually designed that potassium was measured at the given time, and thereafter, patients were observed and people studied whether they died or not. And you could argue that, well, maybe truly hyperkalemia translates into mortality. You could also argue that hyperkalemia translates into something that we are doing as doctors, which then translates into mortality. And this is an interesting observation, and I'll focus on that in just a while. If you're worried about hyperkalemia, this is another reason to start an SGLT2 inhibitor early on, because just as with other adverse events, we see that hyperkalemia, also looking at the meta-analysis, is a lot less frequent if you compare it to placebo. So whenever you're concerned on using an MRA, ACE inhibitor, and SGLT2 inhibitor, go for the SGLT2 inhibitor first. This will lower your potassium and leave you a little more weight. Now, if you have a patient on a ROS inhibitor and hyperkalemia, you basically have to balance whether you want to continue ROS inhibition and take the risk of hyperkalemia, or if you want to discontinue ROS inhibition and take the risk of less treatment benefits. And there are real-life data, and I had the honor to contribute in this analysis from 4 European countries, Germany, Spain, Sweden, and the UK, with 40,000 real-life patients who had hyperkalemia, CHF, and or CKD, and had an incident hyperkalemia. And you see what happened. ROS inhibitor treatment was reduced in Germany in 44%, in Spain in 24%, in Sweden in 34%, and the UK in 57%. And if you look at the outcome, what happens with those patients, you see that pretty constant through all the countries, the patients that were maintained on ROS inhibitors had less morbidity, less admission to the hospital. So reduction of a treatment that is indicated is not reasonable. As a nephrologist, we always manage diuretic treatments and like to focus on some advanced diuretic regimens. And don't worry, we'll not go back into physiology. I will not tell you everything that you really might not have enjoyed back in medical school. But I'd like to point out that the kidney actually is a pretty fascinating place where after glomerular filtration, we have different sites of the tubule where we reabsorb sodium. And the combination of loop diuretics and thiazides is something you've been doing for decades. Now we've been adding SGLT2 inhibitors, and we see the benefit. But here at the proximal tubule, there's another mechanism that we can interfere with, another treatment that we can use, and that's been studied in heart failure, that's acetazolamide. There's studies that showed the clear benefit, and also if you look at another meta-analysis, you see that the cumulative diuresis after 48 hours after initiation of acetazolamide is substantial. Clinical decongestion is of clear benefit, and looking at the kidney, you don't have to worry. There's no worsening renal function. So the addition of acetazolamide is something that works. It's additive. You can put it on top. The study data are clinically reproducible, and you might even have a beneficial effect of correcting some metabolic alkalosis as a result of all the other diuretics. Measurement of serum bicarbonate certainly is useful. That's what I do whenever I don't get by taking the fluid out. And you wonder, why don't we do more dialysis in these patients? And I'd like to focus for the last few slides on the, for me, major problem in treating congestive heart failure. If you have left-sided and right-sided heart failure and pulmonary edema, it's pretty simple. You just have to overall get fluid out, and that's what you can get by with diuretic regimens. For me, the major problem are patients that I see with increased pulmonary resistance and only congestion of the right ventricle with a rather normal left ventricle. Such right heart failure is a problem, and there are studies looking at patients with pulmonary arterial hypertension, and you see that irrespective of the cause, this translates into a really bad prognosis. The patients with GFRs below 60 and pulmonary hypertension have a 50% mortality within a matter of 3 to 4 years. What can you do for those patients? Well, dialysis is something that has been used. Peritoneal dialysis is something that has been used in children, and that's where there are some reports that patients, again, with AKI fare worse, but peritoneal dialysis is feasible. Do we have any other studies on peritoneal dialysis in pulmonary arterial hypertension and heart failure? No, we don't. There's a recent study that's just starting that actually will aim to include 84 patients with New York Heart Association heart failure 3 and 4 with whatever degree of heart failure in order to see if there's any survival benefit. So let me summarize. What did I want to say? The standard therapy of congestive heart failure is also protective for CKD production. Consider intrinsic renal injury, however, in case of rapid progression or abnormal urine examination. Think of dipstick and urine albumin-creatinine ratio. Treat intercurrent hyperkalemia, but continue RAS inhibitors. Combination diuretic therapy may consist of up to 5 different classes of diuretics. And cardiorenal syndrome in patients with pulmonary arterial hypertension is especially difficult to treat, and peritoneal dialysis may be of additional benefit to remove the ascites and have also some gradual volume removal, but that's still to be proven. Thank you very much for listening.